I guess I have one more task to introduce Dr. Kelly Stratton, who's going to be speaking about next generation imaging with the PSMA testing. So, Kelly, I almost walked off.
No, that's great. Thank you. Let me get everything set up. Thank you again for that introduction. Perfect. I'll be talking about next generation imaging and then also an introduction to Theranostics. My name is Kelly Stratton. I'm a urologist at the University of Oklahoma, and I treat a lot of men with advanced prostate cancer there. So our objectives for today are to characterize and compare the current molecular imaging modalities. We'll also discuss next generation imaging and its assessment of men with biochemical recurrent and failed local therapy. We'll look at PSMA PET and how it can be used in men with known or suspected metastatic prostate cancer. And then finally, we'll introduce ourselves to Theranostics and how Theranostics could be used for men with metastatic castrate-resistant prostate cancer. So for our discussion, we'll compare advanced imaging to conventional imaging, and our definition of conventional imaging are CT scans and bone scans. These are widely available images, and historically we've used CT scans and bone scans as a way to assess the clinical states of advanced prostate cancer. So these tests remain important for our stratification of patients, and in many instances the clinical trials that we talk about today had used CT scans and bone scans to categorize patients. However, there are limitations to conventional imaging, particularly in the early detection of metastatic disease. So I think it's important to keep these as an option for ourselves, but then also consider advanced imaging as new modalities that could help us further define a clinical state. So PSMA PET is really the next era of imaging, and up until recently, there were guidelines that recommended if you had negative conventional imaging, you could get PSMA PET as a way to ensure that there's no metastatic disease. But in fact, now guidelines have shifted. Instead of considering these advanced images, they now recommend as an alternative to conventional imaging. And so really there's been a change in practice. PSMA PET is now the preferential treatment for assessing men for advanced disease. And so when we think about PET imaging, really what we're referring to is a radionuclide that is a positron-emitting tracer, like F18 or gallium-68, that's linked to a ligand that has an affinity for prostate cancer. So there's a couple of different molecules that we can look at: choline, fluciclovine, and then also the PSMA ligands. And then we'll look at each one of these imaging modalities. So here are the three approved PET images for prostate cancer. The first is C11 choline, and phosphatidylcholine is used for membrane synthesis. So this is increased in prostate cancer cells. The problem is that with carbon-11, there's a very short half-life. So C11 choline PET, it requires on-site cyclotron and really limits the access to choline PET. The next PET imaging is fluciclovine, or F18 fluciclovine, trade name Axamin, and it is a synthetic amino acid ligand, and so there's increased uptake in prostate cancer cells due to the increased metabolism that we see in prostate cancer cells. Fluciclovine is particularly indicated in the detection of local recurrence, and part of that is because fluciclovine has a lower urinary excretion than the other PET agents. And so if you're looking in a patient, for instance, who had a prostatectomy, the urine volume of the PET tracer doesn't obscure the local recurrence as much. And then finally, PSMA PET. PSMA is a transmembrane glycoprotein overexpressed specifically in prostate cancer cells. And there are two agents that have been approved here: F18 PSMA PET and gallium-68. So F18 trade name is Pylarify, and gallium-68 is Locomets or Illuccix. These PSMA PET has a higher sensitivity than the others, and so it's pretty much overtaken the advanced prostate imaging landscape. With the FDA approval for PSMA PET, initially approved in 2020, December of 2020, was gallium-68, and that was actually just in 2 locations in California, and then since that time it's been more broadly approved and more broadly available. In May of 2021, F18 PSMA PET was approved based off of 2 studies, the Osprey and the Condor study. And we'll look a little bit more at each of these studies that led to the approvals of PSMA PET. So starting with gallium-68 PSMA PET, the studies, there were 2 studies, prospective studies done at both UCSF and UCLA. The first looked at 635 men who had biochemical recurrence after radical prostatectomy, radiation, or both. And PSMA PET was able to localize the recurrence in 75% of men. They noted that PSMA PET had a detection that significantly increased with increasing PSA. And you can see over on the side the bars showing that as the PSA became above 0.5, the detection rate really increased. And then they further looked at patients with isolated metastasis and PET-directed focal therapy to those metastases. They were able to get significant reductions in PSA in 80% of patients who had treatment of those metastases. So that was very encouraging. Subsequently looked at a phase 3 study, again at UCSF and UCLA, of 277 men with intermediate to high-risk prostate cancer who were undergoing prostatectomy and pelvic lymph node dissection. So they had PSMA PET pre-surgery. The median PSA of these patients was 11.1. They detected positive lymph nodes in 27% of patients, and that sensitivity was 40% with a specificity of 95%. Moving on to F18 PSMA PET, the Osprey study was a phase 2-3 study with 2 different cohorts. Cohort A had high-risk prostate cancer undergoing radical prostatectomy, and then cohort B had patients who had recurrent or metastatic prostate cancer. In total, 385 patients were evaluated. They had separate primary endpoints between the 2 cohorts. Cohort A had nodal or extrapelvic metastases, and then cohort B was biopsy positivity. In cohort A, the median specificity was 97.9% with a sensitivity of 40%. And in cohort B, the sensitivity was 95.8% with a positive predictive value of 81.9%. The primary endpoint for specificity was met, and they noted that it had a high positive predictive value. The follow-up to the Osprey study was the Condor trial, a phase 3 trial of men who had PSA recurrence after either radical prostatectomy or radiation therapy. The primary endpoint was correct localization rate, and 208 men were evaluated. The disease detection rate ranged from 59 to 66%, with correct localization over 80%. And so more recently was the reported PRO-PSMA study. This actually compared PSMA PET to conventional imaging to show specifically that PSMA PET was superior to conventional imaging. It was a phase 3 study of 302 men who had high-risk prostate cancer. The primary endpoint was the accuracy of the first line of imaging to detect metastasis. And the researchers found that PSMA PET significantly increased the accuracy in both sensitivity and specificity by 27%. Also importantly, they found that men who underwent PSMA PET were exposed to lower levels of radiation. So I think that that's an important potential benefit for patients who may have serial imaging throughout the rest of their life. Now I've discussed both F18 and gallium PSMA PET, and so depending upon availability, one agent may be available at your site versus the other, or you may have both. When we think about which one may be better, the results seem to be comparable, but maybe slightly different. So this is a study comparing the 2 radio tracers. It's a study of 191 men with biochemical recurrence that were imaged with either gallium-68 or F18. And in fact, 25 patients were imaged with both. They found that for the majority of the PSA range, the detection rates were very similar. Only in the range between about 0.5 to 3.5 did they notice any separation. And in that, the sensitivity for F18 was 88%, whereas gallium was only 66%. In the 25 patients who underwent both imaging, the majority of them, both imaging modalities, were able to detect metastasis. But in the F18 PSMA PET, they showed a slight increase in the number of metastases, so maybe an increase in the sites. If we move on to the guidelines, looking at the advanced prostate cancer guidelines from the AUA in 2023, you can see that as clinical principles, preferentially PSMA PET is recommended in those patients who failed local therapy. And so we start to see that migration in the guidelines that we also see in clinical practice towards recommendation for PSMA PET. And in the salvage therapy, this was already mentioned, but for patients with biochemical recurrence after radical prostatectomy, if you're considering salvage radiation therapy, it's recommended to perform next-generation imaging with PSMA PET. And again, this is to ensure that patients don't have metastasis prior to their salvage radiation therapy. Looking at patients with non-metastatic castrate-resistant prostate cancer, it's recommended that we get PSMA PET as a way to evaluate their clinical state, and that's recommended every 6 to 12 months. I generally do that annually for these patients. And then in the MCRPC space, PSMA PET is used in patients who may be candidates for lutetium to identify metastasis and ensure their candidacy for that treatment. Moving on to the NCCN guidelines, they really state up front that PSMA PET can be considered as an alternative to conventional imaging in 3 different spaces: the initial staging, biochemical recurrence, and also at the time of disease progression. Conventional imaging is not needed prior to PSMA PET, so if you ever get kickback from insurance company, it's very clear to use the NCCN guidelines as justification for upfront PSMA PET. And then they discuss that choline and fluciclovine can be used for detecting small volume recurrences in patients who've had prostatectomy. However, PSMA PET has higher sensitivity, particularly at lower PSA ranges. The NCCN guidelines go on to recommend PSMA PET before the initiation of ADT, just to help improve the sensitivity. And they mention the potential for Will Rogers effect with PSMA PET. And basically what they're saying is that with better classification, we may note an improvement in outcomes, but really we're just identifying metastasis that we otherwise wouldn't have identified. So they caution that changes in treatment based off of imaging should account for that potentiality. The EAU guidelines, very similar to the NCCN guidelines. As far as staging, they state that PSMA PET is more accurate for upfront staging, but again, they caution that outcomes may not be different, and we haven't proven that it improves outcomes. And then for patients who've had recurrence after prostatectomy, offer PSMA PET with a PSA above 0.2. For patients who've had radiation therapy, perform a PSMA PET or fluciclovine or choline if you're not able to have a PSMA PET. And if they have a negative PSMA PET, you should not delay salvage radiation therapy. The EU guidelines also stratify the potential positivity of PSMA PET based off of PSA levels. And so I think you can really see at 0.5 or above, you start to see increased detection of metastasis on PSMA PET. And then finally, we can move on to Theranostics. So Theranostics is the combination of both therapy and diagnostics. It's a treatment using 2 radiolabeled ligands, so a predictive biomarker, but also a therapeutic agent. And this is really where next-generation imaging meets personalized medicine. So we're treating patients specifically at that location where their tumor is. You can see this graphic showing treatments over time with lutetium and the resolution of the metastatic foci as the patient undergoes their 4 cycles of treatment. Lutetium is our theranostic agent. It was approved in 2022. It's a beta-emitting radioligand targeting PSMA-expressing cells. Its approval was based off of the VISION trial, a phase 3 trial comparing lutetium plus standard of care versus standard of care alone. and it required that patients have at least one androgen pathway inhibitor and 1 or 2 taxane regimens prior to PSMA PET. Each patient had PSMA PET positive scans, so they had metastatic disease. In that study, they used gallium-68 as the PSMA agent. Lutetium, which in addition to standard of care, was shown to improve progression-free and overall survival compared to standard of care alone. And the approval of lutetium included the approval of gallium-68 as a way to identify patients who may be candidates for lutetium. It's important to note that patients could also be imaged with F18 PSMA PET and be a candidate for lutetium. The NCCN guidelines specifically support that. So if you ever had a problem getting a patient on lutetium, you can again use the NCCN guidelines as justification for F18 PSMA PET. So in conclusion, conventional imaging is still widely used and historically has been used to define our clinical disease states, but PSMA PET is more sensitive and has from clinical practice perspective really become the imaging of choice. Clinical trials are still necessary for us to understand the potential impact of PSMA PET and whether it's going to improve outcomes, but I think we certainly understand its benefit in identifying early metastasis, and lutetium represents our first-in-class theranostic agent that can be used in men with metastatic castrate-resistant prostate cancer, improving survival in patients who've previously had an androgen axis drug and then also chemotherapy. All right, that's the end of my talk. I think we have clinical cases next, right? Dr. Borjan's gonna come up and give us a talk on biochemical recurrence in high-risk patients.